Okay, welcome everyone to our Saturday speaker meeting. Today we have, I'm excited to announce that we have Dr. Mohammed Ahmed, who's a neuropsychiatrist and medical director of the Kaizen Brain Center in San Diego. Dr. Ahmed is a specialist in both memory disorders, dementia, and brain injury medicine. So today's topic is brain injury assessment, diagnosis, treatment, and developing a care team after brain injury. So with no further ado, we'll get started here, and please join me in giving a warm welcome to Dr. Ahmed. Thank you for joining us today and spending some time on a beautiful Saturday with us, sir.
Thank you, Kurt. Well, it's my pleasure actually to give a talk today. I'm also on the advisory board for the San Diego Brain Injury Council, and and I've known Kurt, and we've talked a lot about a team model, care model for TBI, and I think so today's talk is I'm going to highlight a little bit about what is TBI and the care model, comparing it to the DIVBIC model, which is the defense injury program at Camp Pendleton, and share some data from that. So TBI has been very close. I've trained in TBI way back since 2008, and bulk of my training has come from treating veterans from the war coming back from the injuries. I've learned about TBI, and there was a point in my life where I didn't know what TBI meant. Then I relearned again. So there's this stages, and so I'll share some insights from my training experiences, what I've learned, and I continue to learn. I don't think, nobody can call themselves as a TBI expert. I think we're all learning. So there's this constant state of learning. So let me get the slides on 1 second. All right. So that's me. So I'm the medical director of at Kaizen Brain Center. It's a small private practice in San Diego that was not started from a business model of a medical practice. Back in 2016, I worked to understand the relationship between a traumatic brain injury and how it leads to Alzheimer's, and worked on some research, and we presented a paper at the Alzheimer's International Conference, and I think that literally became the model for Kaizen. So, so that's how we've treated our patients, managed our patients, followed our patients. So I will present some insights from that today. So the agenda for today's talk is I'll just give a brief outline of concussion, traumatic brain injury, and the post-concussive syndrome. I'll talk about the whole spectrum without delving too much into definitions and all that stuff. I'll talk about the link between TBI and neurodegeneration, which is very fundamental to what we do at Kaizen. And then I'll talk a little bit about the diagnostic approach. What are the treatments available? Then I will talk about the interdisciplinary model at, that is at DIVBIC, that is Defense and Veteran Brain Injury Center, and a model at Kaizen, what we have done, what we have learned, how we have adapted, even during COVID. Talked briefly about a few cases within that interdisciplinary model and how that changed the outcomes of our patients. So next, so what is TBI? Basically TBI is, there's no standardized definitions, but I think according to the Brain Trauma Foundation definition, if you look at it, and what it says is there is a change in a brain function following an external force to the head. All this could be accompanied by a loss of consciousness and also have other neurological or cognitive dysregulation. That could be, you could have a headache after concussion, or you could have a cognitive impairment as a result of that. So all these things constitutes a TBI. Now, a TBI based on the severity could be divided into a couple of stages. One is a mild TBI, the other one is moderate, and the other one is severe. So the mild TBI is the most common form of TBI that's we see in a lot of our population, particularly in the military as well. And this mild TBI is interchangeably used for concussion. So generally concussions and mild TBI have been interchangeably used. Concussions largely in sports injuries as well, but they mean the same. Then there is a moderate TBI and severe TBI. The difference, how you differentiate them, is based on the neurological symptoms that I mentioned before. Loss of consciousness, alteration of consciousness, amnesia, memory changes after the concussion. And based on the duration of the symptoms, you divide them into mild, moderate, or severe, or even sometimes based on the absence or presence of hemorrhage in the brain. Generally, mild TBIs don't have hemorrhage in the brain. When they have hemorrhages, they usually go to moderate. Severe TBIs are ones where people have been in prolonged state of loss of consciousness, could be coma for a couple of days. So those are the severe TBI.
How about, this is Kurt, how about loss of consciousness in regards to concussion, quote unquote, mild TBI? Do you see loss of consciousness and mild TBI? Is that an indicator? Or is that more pushing something to moderate?
Yeah, so largely it's mild, again, depending on what's the duration of your loss.
Duration, okay.
So if it's, it's 30 minutes, they say, but I really don't, I think that's a very old definition. And also because we have to be careful, there has been about 40 to 50% of the people who do not have even loss of consciousness go on to have a full-blown post-concussive syndrome. We see that in, veterans who've been exposed to ID exposures. Now
exactly. Yeah.
They never have a loss of consciousness, but they have brain changes.
Yeah.
Indicating of TBI. We see in women soccer players, just the act of heading could be considered as a mild concussion. Albert Einstein University is a cohort that they're following, and there's some interesting data coming out of that. So loss of consciousness cannot be taken as a sole single variable. I mean, I think that's the biggest problem, I think, in a general practice, is we say, oh, you didn't lose consciousness, so you probably don't have a concussion. So I don't think that's completely true.
Exactly why I asked. Yeah, thank you for that clarification.
Yeah, absolutely. So in this slide, I want to highlight, today, let's say you have a concussion today. What are your symptoms? All right. So if you look at on the left side, largely problems with visual impairment. Typically people, young students say, well, I can't, my screen endurance has gone down and I can't see the screen well. I get light sensitive, sound sensitive, I get headaches. I can't focus better. Problems with dizziness, gait, they get mental fatigue. It's usually called as brain fog, like I'm very foggy. Those are the order of severity of symptoms. And people can get migraines, headaches. Not so much depression, anxiety right away. We're talking about less than 10 days after once you have the early first week of the concussion. And 98% of the symptoms get better. People, if you had a head injury, of course, you are going to have some symptoms. So 98% get better. Now, what happens next after 10 days? People, the minority of population who do not get better go on to have what is called as a post-concussive syndrome. Now, there is a duration. People have divided into acute and severe. Acute is like after 2 weeks to 6 months. Chronic is after 6 months. But again, we can debate all that stuff. But generally, there's an acute state and a chronic state. Now, you see the symptoms on the right side have changed. The visual impairment, balance issues are no longer the most common. The most common now are depression, anxiety, PTSD, headaches, migraines, cognitive fatigue. If you look at these two comparisons, there's something interesting thing has happened here. A neurological event of a TBI, which is the definition of TBI or concussion, has now transitioned into a neuropsychiatric symptom. You have depression, anxiety, emotional dysregulations. So there's this heterogeneous symptoms that people start to have. And that's the most important factor in this. So then, many years after you've had concussion, there's a certain set of population that go on to have what is called as NDD, which we call as neurodegenerative disorders. we have no good understanding of which is the population that go on to have this. We are beginning to understand some role of genetics in this. Like for example, one such group is goes on to have Alzheimer's disease, and we are starting to understand that when they have a ApoE gene, E4 allele, which is one of the gene that puts you at risk for Alzheimer's, and you also have a concurrent TBI, your risk of getting Alzheimer's is relatively high than the general population. A certain group of that post-concussive syndrome patients go on to have CTE, which is chronic traumatic encephalopathy, which is seen in, largely it's been noticed in football players, but I think we are beginning to understand that it's not limited to football players. There are other groups of sports that have been reporting this pathology. Yeah, largely I think there's a context of repetitive head impacts. Then another group of post-concussive syndrome people go on to have motor conditions, motor disorders, which we call as Parkinson's, ALS. Muhammad Ali, the famous boxer, had Parkinson's. So these are the things that people go on to have. I think, and we don't really understand this, the trajectory of this, simply because we've really not followed this group of the middle on a longer duration with a good sets of variables like biological biomarkers like the cognitive testing, MRIs, abnormal proteins. So I think the studies are underway, but we don't have a good idea about that. So that's something that the holy grail of the long-term sequelae of TBI. Right now, so I'm gonna focus on this aspect of it, the NDD aspect, and in that Alzheimer's particularly. So this slide is basically how we formed Kaizen. Because TBI is a risk factor for Alzheimer's, you need to look at it from a holistic perspective, from the prism of Alzheimer's. Imagine, when I was training when I was seeing veterans with brain injury, there are two questions that are raised. First is, help me with my symptoms. Two is, what's my future? Am I at risk for something in the future for such as Alzheimer's or some CTE? We really have no idea to say who are the people who are at risk. So I think, so it was absolutely important to follow them carefully in a very interdisciplinary approach. And I think that's pretty much why we started Kaizen. And I think that's been fundamental to approach. So like I said, I think, the first paper, this was a poster that the paper research at UCSD when I was a fellow. I think what we looked at was all the people who had autopsy confirmed Alzheimer's at the Alzheimer's Research Center at UCSD, and went back and asked the question, did they have a head injury? So if they did they have a faster progression in the dementia? So we had two groups, one group who had the TBI, and the other group, which did not have the TBI. So we found that the people who had TBI had a faster progression. And that was a poster that we presented at the 2016 Alzheimer's International Conference. Now below that is another study, which is a review article just recently published by Raquel Gardner at UCSF. She's a brilliant behavioral neurologist who is probing the relationship between a head injury and neurodegenerative disorders. She's done some amazing work in this field. And I think in this paper, which is just recently, it's still in press, but what it concludes is that it was a systematic review of TBI. And then what they alluded is that independent of the severity of the TBI, whether you have mild, moderate, or severe, the risk of all-cause dementia, which is Alzheimer's, Parkinson's, motor, any cause of dementia, goes up by 63 to 96%, which is quite significant. And this is not, this is a lot of, it's been replicated in other groups. So now we know that TBI is a established risk factor for risk of neurodegeneration. Now, how do we do this? Like I said, at Kaizen, we really wanted to follow these people, not just address the current symptoms, but understand the risk of Alzheimer's in the future. So we are doing a study that is basically a lumbar puncture, a spinal tap. So what we do is, in some of the population patients we see with TBI, we take some of the fluid from the back of the spine and look for this proteins called amyloid and tau proteins. Now, amyloid, this is a standard test for diagnosis of Alzheimer's disease. It's a very good diagnostic tool, and it confirms the presence of Alzheimer's. And we know the cutoff in patients with Alzheimer's and tau. In people with, we know the cutoff for Alzheimer's, amyloid and tau, sorry, in patients with Alzheimer's, but we don't know the cutoff in patients with TBI. So that's the goal of the study, to understand the cutoff here. But we still, despite being a study, I think it has directly helped us to make some informed decisions about our patients as well. For example, we had a patient who's young healthcare provider who had a concussion and had features of CTE, and and when we did the study, the tau protein, which is particularly correlated with chronic traumatic encephalopathy, was severely high, extremely elevated. And so we were able to make some informed decision as a result of that. So it does help the patients. The second thing is, there's some interesting biomarkers that are coming in the market. One is plasma amyloid and plasma tau. So in short, what happens is, let me just give you a little bit of science on these two proteins. When you have a head injury, what happens is you have this axonal injury, because the axons are the covering neurons, the central part of the neurons, and they have a tear. And as a result of this, they form this thing called plaques and tangles. And these plaques and tangles accumulate a lot, and once they accumulate a lot, they can trigger a neuroinflammatory cascade. And this neuroinflammatory cascade initially can be protective, but over a period of time can trigger neurodegeneration. So let me give you a parallel example. When you have a knee injury, you have swelling, redness, pain, and that's a sign of inflammation, right? Now, when it's good. Inflammation is designed to help and, as a part of the initial response. But if you do not address that inflammation over time can start to damage the tissue around the knee and create a long-term impairment. So these proteins may indicate that long-term impairment process in the brain. Now, as I said, we are able to only do it through the spinal fluid and take that out and look for that proteins. But the plasma is blood. We don't need to go and tap your spine. We can actually just take it from your blood and measure those proteins. The plasma amyloid is already out in the market. It's not covered by insurance yet, but it's out. And the tau is still in a research state. But I think hopefully by a year or two, we should have it available for the clinical setting. So these are some interesting things going on in early detection. There's also lots of interesting work being done using predictive modeling, artificial intelligence. One of the things that we did in the past was looking at combining the genomic data and combining the neuroimaging data along with some cognitive testing and predicting who is at risk for developing Alzheimer's maybe 5 years, 10 years down the lane. And that's important right now because previously we didn't have much options, but now within the new disease-modifying drugs that are starting to come into the market, I think this might be a very interesting time, because if we see that pathology, we can go after it and fix, address it, or perhaps get into a clinical study. So I think this is some exciting times for all this early detection. So diagnostics, how do you approach a diagnostics in TBI? I think the fundamental to a good diagnosis of a TBI is clinical evaluation with a good neurobehavioral exam. In my practice, I get patients all the time doing this fancy test from here, spending thousands and thousands of dollars and saying, well, I did the scan, it showed TBI. Honestly, I don't know what to do with that scan. You can never diagnose a condition based on your scan. For example, we see patients with Alzheimer's. It's a clinical diagnosis. We don't diagnose, your MRI and say you have Alzheimer's. You have to have you have to have the symptoms. You have to understand the progression of it. So so fundamental to any clinical to diagnosis is your clinical evaluation. Now, to confirm your clinical evaluation, you need to choose an appropriate neuropsych testing. There are varieties of tests. I don't think one test fits all. You have to understand what your needs of clinical evaluation is, and then choose appropriate test. And then you can confirm that with doing neuroimaging. The most common neuroimaging is structural MRIs. There's some good sequencing that we can do using like a diffusion weighted imaging, diffusion tensor imaging, MRS, Mars spectroscopy, neurocont, where we actually quantify every area of your brain and understand where it is kind of like shrunk compared to the average population. So I'm not going to delve into this. I'm just going to run through it. But if you have questions, please feel free to ask me. Then there's another type of neuroimaging called functional imaging. Generally it's very limited in TBI. There's really, you can't look at a functional image and say, well, look at it, that's TBI. No, you cannot. The only functional imaging we perhaps can use is the amyloid and the FDG PET for Alzheimer's. Let me give you a scenario. When I have a concussion, a 70-year-old male with a concussion, and I'm worried that he may be going towards Alzheimer's as a result of TBI, that's when I would use this test. It makes sense. So you really have to understand when to use a tool. You can't just blanketly use all tests you have and say, well, I did everything. It doesn't work that way. This is if you can say Alzheimer's diagnostics and approach is a classic example of a precision-based personalized medicine. There are also interesting technologies we can use this. SyncThink. It's a virtual reality goggles that was developed at Stanford, and we can use that to understand oculomotor and vestibular assessments. You remember in this first slide, I said the first thing that you have after concussion is the vision and the vestibular changes, the balance. And I think that this is a very objective diagnostic tool, and it's been a game changer for us, how it has helped us with the clinical assessments. And also because the post-concussion syndrome, we are beginning to understand that everybody don't have the similar symptoms. We're beginning to subtype it. Some people have, like a vestibular problem. Some people have, vision problem. Some people have headaches. Some people have cognitive. Some people have emotional dysregulation. They cry easily. Some people have PTSD spectrum of symptoms. So you really have to kind of like understand what is that, which subtype it is. And that is, you don't need any test for that. You just need this clinical evaluation to do that. Simple. There's some role for labs. We do get some endo panels for some patients who we think that could be affected. There's some evidence coming out of, there's a consensus paper that was written that said that we should do some testing for certain people with concussions. TSH makes sense, B12, folate, vitamin D, all this initial basic lab work could be helpful. Then again, we can do the lumbar puncture, as I mentioned, to look at if there's any amyloid or tau. You have to also learn where to use it. Again, if you have a 20-year-old with concussion once in a while, does it really help? Probably not. You have a 70-year-old with concussion has progressively cognitive decline. Yes, of course, there is a definite role for that. Now, this is what the icing that the device I was talking about. It's from Stanford, and I think we've been using it for a while, and it's really helped us to parse out what we need to do with the concussion. So because like I said, concussion is like a team effort. You need a team, and you need lots of variables, and you need to understand the subtype and get who to get involved. I think that's, so this is just a picture of the position. So it measures the smooth pursuit of the eye, and it also looks at the vestibulo-ocular reflex. The smooth pursuit essentially is a function of your visual attention. Often people with concussions, when they say, well, I can't pay attention, and I think that's important to address, because its relationship to driving, and I think, I'm always concerned about driving and concussion, because, if you have poor visual attention, and, can you actually drive? Can you pay attention to the road? So I think that is something that we really have to pay attention. And this test has helped us guide in that, and keeping, we tell our patients, if it's really abnormal, I think you shouldn't drive. And I think that's a very important aspect of the management. Now, treatments. So again, like I said, concussion is, we have to subtype it and understand, and then go after that. So there are some medicines that can help with cognition. The first two medicines, rivastigmine, Namenda, these are actually Alzheimer's medicines. And I've prescribed them to as young as 20-year-olds, to the fact that I've got calls from the pharmacy and said, I think you made a mistake, because this is 20-year-old, this is an Alzheimer's medicine. It's still fine. I think there's a science to it. Rivastigmine can help with the executive dysfunction with the concussion. Namenda is a drug that we use in moderate Alzheimer's, but in the case of concussion, it can be helpful because it reduces the neurotoxicity that can happen after concussion. I think, like I said in the previous slide, there's a neuroinflammation going on, so it may perhaps help calm things down. And we've had some clinical evidence with that, and there's some anecdotal data as well. Ritalin is a stimulant that we can use for people who have attention deficits after concussion. It's been used. There's enough evidence to support that this could be an initial medicine that can be tried for attention deficits. It's relatively safe. And then we've also tried amantadine. From my clinical experience and even some anecdotal data, amantadine has been particularly helpful in improving motivation and brain fog. Not everybody responds to it. You really have to parse out based on your cognitive testing. But when they do respond really well to the brain fog. Especially during COVID times, we're really interested to see if it may have a role in post-COVID brain fog as well. But because some of our patients have had COVID and they've already had a brain fog from concussion, and they had a COVID and the brain fog got worse, some cases amantadine has been very helpful. Then for mood, SSRIs, the Prozac, all these things can be tried, but because of the concussion, usually people don't respond to it. Like I said, concussion is an axonal injury, right? So axons is the one that are connected to each other. If there's a structural damage, usually we feel that the medicines may not actually be that helpful. Trintlex, however, because of a different kind of a mechanism of action, has been helpful. It's improved the cognitive processing speed in some of our patients, and also to some degree, the brain fog. Then there's also some good evidence for Nudexta, which is a drug, FDA-approved drug for pseudobulbar affect, where people have emotional dysregulation. They laugh or cry too much, largely in a neurological condition like ALS. Alzheimer's. And also we are seeing that this could be helpful in patients with TBI. I don't think in patients with TBI, they laugh a lot. It's only the crying aspect. They have a lot of emotional dysregulation. They cry trivial things. So Nudexta has been helpful in that, controlling the symptoms. And also based on the mechanism of action of Nudexta, it's also been helpful perhaps in reducing the neuroinflammation that we see as a result of concussion. So, all right, there you go. And there's then a headache. Headache is a very, very important aspect of concussion. I think almost 40% of the post-concussion symptoms revolve around headache. Now, the reason I'm talking about headache is to state a point. Oftentimes in our practice, I see patients with TBI are undertreated with headaches. They're often not treated at all. I don't understand this phenomena. It's, and when I ask them, I say, well, even with a lot of colleagues, well, it's a headache. These medicines are largely for migraine. So this is a post-traumatic headache. So I don't know if it's can be used in this context. Of course it can be used. You can use it as off-label. It doesn't matter. It's like saying, oh, you have depression because of stroke, so I'm not going to give you any depression medicine. That doesn't make any sense. You treat the symptom, period. Of course, it will be considered off-label because, people do get headaches. Particularly the post-traumatic headaches is a very mixed phenotype. You have a little bit of migraine features and a little bit of tension headache features. You really have to pay attention and parse that out. But there are medicines available. There are, the typical medicines are like, we have used, in the past, we've used antidepressants like Elavil has been a great medicine. Nortriptyline works really well for post-concussive headaches. Topamax, all these things work. But the problem with these medicines is, one way they help the headaches, but they can cause cognitive difficulties. Particularly Topamax can cause word recall. So you're trying to help one thing, but if they also have associated cognitive problems, you can worsen that. But the Aimovig particularly has been a great boon now in terms of post-traumatic headaches. I think there was a study that was just recently published in the Journal of Headache and Pain, looking at the efficacy of this drug. It's an injection that you give once a month. It's very well tolerated, and this can help with post-traumatic headaches. We've actually had some very interesting results from this, from using Aimovig for post-traumatic headache. And it's important to address. It's like saying, let me give you a comparison. Why is this so important? I described you about the neuroinflammatory cascade, right? As soon as you have a head injury, you have this, diffuse axonal injury, the neuroinflammation and stuff. When you have an injury to your knee, and you have this swelling, pain, redness, inflammation. So it's a sign of inflammation. When people complain of headache after a concussion, that is also a similar sign of neuroinflammation. That's how it's like a brain pain. You can't see it, but it doesn't mean it's not happening. So to me, I think, Kurt, you asked me the question, loss of consciousness. I don't just believe in loss of consciousness. I think the critical variable I assess is headaches, because post-traumatic headache could be the sign of a underlying neuroinflammation. The quickly you suppress it, the better it is. It's like, similarly, if you keep the neuroinflammation going on, then it's going to have long-term sequelae, long-term damage to your brain tissue.
Yeah, very interesting. Yeah.
Yeah. So this is really important to address, and it can be addressed. It can be addressed. I mean, so I think that's something I want to state. I have the data for the study. If somebody's interested, I'll be happy to elaborate much on that. Then there are also abortive treatments for headaches. Typically, I won't go into details, but there's IV injections like that you can use. There's sumatriptan, that Imitrex that people may know. You use it as needed to abort it. The intranasal form is coming. There's lots of new treatments. The main thing to highlight is this one, Nurtec. Nurtec is usually is one of those abortive medicines that was recently used to abort the headaches. But just about a month ago, I think FDA approved it for even prevention. So that's again a huge game changer. So I'm not going to delve too much into this because my colleague Dr. Ansari would want to come and talk if we have to do a series of talks, and I think he'll give a much detailed explanation of most of these medicines. And of course, there's also a role for Botox in post-traumatic headaches. But you have to carefully select your patients to a specific treatment. Now, sleep, fundamental to post-concussion, often under-addressed. There is about 30 to 35% of prevalence of obstructive sleep apnea in patients with concussions, especially whiplash injuries. And it's often undertreated, underdiagnosed. I think it's fundamental to everything. I mean, you cannot address cognition, mood without addressing the sleep. I mean, you and I don't sleep for a few days. We don't function. We can't function. Our mood is irritable. So there's no point in going and fixing the mood and cognition without addressing the sleep. It doesn't make any sense to me. I think that's very, very fundamental. I think what we have done is in our team, we have sleep neurologists. So we get a sleep study, which is at home, understand the sleeping patterns. There's also people can have, so one way to approach sleep is to understand whether you have trouble going to sleep or maintaining sleep. And there are different medicines for that. For going to initiation, you use Lunesta, Ambien, and other medicines. Maintenance is Neurontin, pregabalin, Circle. And so you really have to understand a little bit more integrity of the sleep architecture. People with concussion also get REM behavioral disorder, like people act out in their dreams. This is not night terrors. Night terror is a different thing, but this is more a behavioral dysfunction, and we sometimes use Klonopin because of that, and also melatonin can be helpful in some cases. Then people have narcolepsy; they just fall off sleep, and there's Xyrem is one of the medicines. It's a very controlled substance. Then people have nightmares. This is a part of the PTSD spectrum. The FDA has approved a prazosin, which can be helpful in controlling those things, the nightmares. So just an overlying idea about the sleep management. Then the treatment-resistant depression. So, concussion, TBI leads to, like I said, subtypes, right? So you have headache, you have cognitive, you have mood, depression. Oftentimes we treat, the depression that happens after a TBI is a treatment resistant. And it's not the same depression as you see without people without TBI. These are very fundamentally different pathologies, and their even presentation is quite different. So at Kaizen, this has been something that we've really paid attention and parsed those things out. And we've done, because it's treatment resistant, doesn't respond to most of the medications, we've done brain modulation, and this is called as transcranial magnetic stimulation, which is basically a coil that's, in the picture as you see, we put it over the front of your scalp and stimulate the area of the scalp with magnetic pulses. After doing a lot of investigation about where to target and all that stuff. So, and this is painless procedure, well tolerated, done. You can drive in, drive out. It literally takes about 4 minutes now with the recent protocols we have. And this can help with the depression and also with the inducing what we call as neuroplasticity and improving your cognitive reserve. We have done, this is a FDA approved treatment for depression, and I think there's a gazillion centers around us doing this. I think what we have really specialized or found our niche is doing in context of people with concussions, with a depression within the context of a post-concussive syndrome. That's something that we have learned to do well. And I think in a future talk, I'll present our data. We've had lots of data about that. So, and then there's a new thing called Spravato, which is a ketamine nasal spray that is also FDA approved for treatment-resistant depression. Again, we've used in context of a concussion depression as well, and we found some interesting data with this because we've got some, we think that this also could be one of the tools to address the depression after a concussion. A little bit more about the TMS, the previous treatment that I talked about. This has been our niche. I think I gave a talk a couple of years ago at the Scripps Brain Injury Conference, and I think the talk is still there. You can look at it. We do the TMS quite differently than a lot of people. So, we don't blindly put a magnetic coil over the brain scalp area and just carpet bomb it or, just do it. I think what we do is we try to get a functional MRI and understand your brain map. Concussion is a circuit disorder. Your brain is connected to different parts of the brain are connected by different circuits. And we begin to understand that. So we need to understand where the circuits are in your brain. So for that, we do a resting state functional MRI. And we send that, it's done in San Diego, but we collaborate with this guy, Dr. Sean Siddiqui at Boston, brilliant guy, neuropsychiatrist, trained at Harvard. And we collaborate and we understand where your circuits are located in your brain. And based on your clinical features, we target a specific circuit for you. And that's been a game changer for us. And I think we've had some fantastic results for patients with concussions. And this study was a first of its study where it was published in Journal of Neurotrauma, showing the proof of concept. It was a double-blinded pilot study, but it showed that this is the way to treat treatment-resistant depression with TMS. And I think there is a big study underway at Department of Defense where the same technology of Dr. Siddiqui is being used to, I think it's about 1,000 veterans with brain injury. I think the data will be out perhaps next year, but there's some interesting work in that area. Now, this is again the same, slide about a little bit more about, this network-based targeting, personalized TMS that we do. Just to, folks at Harvard actually did a interesting work, and they identified that, your depression has two subtypes. One is a depression that is typically with a lot of sad symptoms, anhedonia and stuff, and then another type of depression with predominantly anxiety symptoms. And these two have different circuits in the brain. So that's what it is about. One is the dysphoric target, one is the anxiosomatic target. So I think that's been the purpose of us to parse this out and understand where to stimulate. So this is one of this network-based targeting that we do. In some cases, we've also done patients with concussions also have problems with cognitive function. And cognitive function can perhaps be involved with an area called the hippocampus, which is the area that controls your short-term memory. And that is fairly deeper. And the TMS does not go so deep. The penetration of the magnetic pulses are not so deep. So in that case, what we try to do is understand what's the circuit it's connected superficially. So for example, the white circuit is the memory circuit, and that's, it's quite deep. And then we understand what is it connected to cortically, the superficial area. And we target here, and the pulses can be tracked down. It can coordinate, it can be passed down, and we can target the deeper areas. A parallel example is some research done in Parkinson's. Like for people who have Parkinson's, they have a problem in the subthalamic nuclei, and it's a deeper area. So that's why they do what is called as a deep brain stimulation. They drill a hole, they put a probe there and modulate the circuit. But I think now we are trying to understand using TMS and see what is it superficially connected to, and we can stimulate that, and the pulses can go down and avoid this very invasive surgery. So, so this is how it works. So basically the process is basically, it's like this. If you go stand out on the road and I call NASA and say, hey, tell me where you are located, they're going to give me some coordinates like latitude, longitude, and that's exactly what we get. So we get the scan here, and Dr. Siddiqui gives me these coordinates. We have a neuro navigation system, it's like a GPS. We plug in the coordinates and we can get to the specific area. So it's very precise in our targeting. So that's something that, that's been a great tool we've had for some of the patients with the TBI. Now, the other form of treatment is the cognitive rehab therapy. I think there's there's a lot of evidence about using in concussion. For many of you who may not know, this was adapted by lots of the veteran medical centers throughout the nation. And I think UCSD was the first one which actually made the best use of this therapy. It was implemented at the VA hospital in San Diego. So I think what we've done is we've use the fundamental principles and try to go and improve it in a very interdisciplinary manner. So basically, if I have to explain to you what it is what we do is we look at the cognitive tests and we understand what are your strong and the weak areas. And then we use this cognitive rehab therapy to focus on the weaker areas. And we using awareness training, behavioral management, memory remediation, social skills training, psychoeducation. So, think about it this way. When you go to the gym and you have an option, you can actually go and work out every muscle of your body and do your own training. you may or may not have a very proportionate body as a result of that. And, but if you perhaps have a personal trainer and he or she can help you to structure exercises that you have a more proportionate outcome. So basically a rehab specialist is a personal trainer for your brain. The CRT is like the workout, cognitive is, and Kaizen is the gym. So, just to give you a little bit of what it is. So this is one of the things that we've really had great success with as well, especially combining with the other forms of treatment, especially when we have learned to combine this with the brain stimulation. I think the results are definitely much better. Think about it like this. If your brain is like a plastic cup and you put it in a microwave and that's your brain TMS, so you've made the brain neuroplastic. Now you can use cognitive rehab therapy to kind of like modulate the circuitry. So it kind of works well together. And there's another thing, another intervention, neurofeedback, which is phenomenal. Again, in some of the patients, we use a brainwave to cause a feedback, and it's usually with the EEG. So we have a helmet, we plug it on, and it's connected to your laptop, and you can see your brain waves, and you can actually modulate them. It's through a mechanism called operant conditioning. You teach yourself to self-regulate. So this is one fantastic tool that we've been using for some of our patients as well. So then there are other treatments. It's just not this, lifestyle modification. I'm a big believer of this. I think this is one of the most important intervention, although I put it in the one slide, one line, but by far the most evidence-based in overall brain health. Diet and exercise can change things. Food is medicine. Exercise is medicine. I cannot understate how much this is important in improving overall brain health. Then there's another thing called accelerated experimental dynamic psychotherapy. It's a more trauma-based psychotherapy. We've had some recent success with a provider in the community, Penelope Andrade. She's fantastic, and we've had some real good success with some of our patients. Then there's another EMDR has been helpful in patients with PTSD. We also do visual rehab. Remember the test I showed, the virtual reality goggles. So when we have that any problems with that, we reach out to some of our visual rehab specialists. These are neuro-optometrists. During COVID, we were collaborating with Dr. Surbhi Bansal at Stanford. So she was able to see some of our patients virtually and perform some of the maneuvers virtually, a virtual rehab and it was great. We've got some great success. And we also collaborate with Dr. Lisa Weiss, who's a fantastic asset in San Diego, who's a neuro-optometrist, and they're very collaborative. Then there's a role for acupuncture, I think in some of our patients and pain and other, post-concussive syndrome symptoms. So overall, you see, this is a whole dynamic team that you have to have to address different features of concussion. Now, interdisciplinary model, I think, is defense. I think by far, like I said, I trained in the VA system. I think it's got a fantastic model of care. Polytrauma care system that was implemented back in 2008 for the OEF, OIF veterans, and then I think they've really understood this very, very well. And the DivBIC model, which is in Camp Pendleton, is fantastic center where it's got all the services you need for people with TBI, and they have a really good team and work in an interdisciplinary approach. So they, this is their team basically, because they see all sorts of TBIs, not just mild, but moderate and severe. So you can see the extended group they have. They have all therapists, including physical, occupational therapists, speech pathologists, which we don't have because that's something that we refer them out to the other PTOT specialists, sometimes at the Scripps Brain Injury Conference, Scripps Outpatient Rehab Program or other providers outside. So this is one of their model, and what they really did was very interesting. So they actually ran a study to see if this model of care works. So they they wanted to know if this model can improve cognitive outcomes and functional outcomes. And, and then I think they did use the automated neuropsych testing to see if this works. So what they really found was by implementing a interdisciplinary model, there was an improvement in the cognitive function, especially in cognitive speed processing, learning, memory, reaction time. They also found a functional improvement in, people were, active duty, where they were retained on active duty, and they also found that they took less time to return to redeployment. So again, it's an initial study, but again, this is a good data point for us to understand that interdisciplinary model does work. Then we have our own Kaizen model. So we don't have every aspect of the DivBIC model, but we do address some most critical aspects of it. So that's us. I think I didn't know what else to do. I think we put our pictures together. So this is basically a model of a team. So, I'm a neuropsychiatrist, and I think, I'm sort of the quarterback for the concussion. So I think, when I said the clinical evaluation, so that's me. I try to pay attention to the clinical aspect, and then I understand what are the subtypes of it, and get the right team involved based on the presentation. So then Dr. Nissinen is a sleep neurologist. He also trained in memory disorders at UCSD after me. And then Dr. Ansari is a headache neurologist. Ida Babakanian is a neuropsychologist. She also works at the DivBIC Interpret Center at Camp Pendleton. She does neuropsych testing for our patients. Jennifer Sumner, Dr. Jennifer Sumner is a neuropsychologist who does cognitive rehab. That's her area of specialization. And Dr. Lisa Black is clinical psychologist who specializes in neurofeedback. She's also a faculty at UCSD. And so basically we work as a team. And I think that's been critical. Like you have one quarterback who's actually, I've trained in TBI, and who understands and gets the right people involved based on the clinical presentation. I think that's pretty much what you need. And you work closely. And what we've learned within our model is, you really, it's not about the interdisciplinary. A lot of people talk about interdisciplinary approach, and it's not just looking at each other's records on the EMR. That's interdisciplinary. Interdisciplinary means actually having a talk with your colleagues and say, hey, I saw this. Can you help me with this? Or let's collaborate on this. Oftentimes, we have had one patient, and three of us have seen the patients together just to get a better outcome. And and just learning to understand and fix those pieces together. Because TBI, post-concussion syndrome, is like managing diabetes. It's not like you did this today and it's all done. It's like walking on this fine line, and you try to do one thing and that gets better, and you see another thing gets worse. So it's like managing and reusing your resources in the right way. So it's basically a chronic management. So talk to you briefly about the case studies. Kurt, I don't know how much time I have. Am I running over? I can.
No, you're perfectly fine. We have up until 12 o'clock, and sometimes we end around 11:30, 11:15, 12. Totally up to you. Yeah, plenty of time.
I'm just trying to, of course I can't put everything in 1 hour or so. It's a lot of, so I'm just trying to give a brief overview about it. And
that's great. And then if we have a little time for Q&A, there's definitely some questions that have popped up in the chat that I'd like to respond to.
Absolutely. Okay, great. And then I think I talked about that. Okay. All right, great. So so I'll give you a couple of, there are lots of cases, I'll talk a couple of cases here. Most recently we had this, this young CTO of a company, a 33-year-old male who had a concussion. He had a concussion and he had a CSF leak. The fluid from his brain started leaking from his ears. And he was previously seen at UCSD, and he was diagnosed with postconcussive syndrome, also had PTSD. He had a previous history of OCD, which actually got worse. He had a generalized anxiety disorder. So he was referred, first he also had headaches. So First, Dr. Ansari saw him and for his headaches, and he was trying to manage his headaches, but I think he felt that there was something else going on that was triggering the headaches, and that was the underlying severe anxiety that was speaking up, and also the sleep. He was acting out in his dreams. He was hitting his wife, and to the point that she could not sleep in the same bed, and she had to move to a different room, and that was perpetuating his headaches. So he felt that, well, we need to address this. So he saw then, he saw my colleague, sleep neurologist, and he said, well, it's hard to say. It looks like we got the sleep study, but it looks like a REM behavior disorder, but it could be night terrors. It's hard to explain what it is. So he felt that, he needed me, and then I got involved. And then we realized, what is it? Is it REM behavior disorder? Or is it a nightmare coming from PTSD, which he already has? So it was a very difficult diagnosis to make and separate. So we said, all right, let's just lean towards PTSD because we know that he has it, and perhaps that's what it is. And so we tried prazosin, didn't work. In fact, got worse. Then we tried Klonopin, which is largely given for REM behavior disorder, works like magic. Finally, he could actually sleep, and his wife was not concerned about him anymore. So that was the initial success. But then again, like I said, TBI is like a complex, you have to keep doing it. But then we only addressed one part of it. The anxiety was still there. It was perpetuating his OCD. It was addressing his, worsening his cognitive status. He is a CTO. Imagine CTO, he has a great executive function. He could run things for his company. On cognitive testing, he had deficits across domains, largely executive. Memory was impaired. So then we kind of had this approach of where we started understanding what is the driver in this, and see if we can address that, and then everything else settles down. I think through an interdisciplinary approach, we found that the driver perhaps is the anxiety. We really needed to control his anxiety. There was a lot of times where his anxiety was even worsening his suicidal ideations, and we had a real discussion of getting him admitted to the hospital, but he was reluctant. He's never had any psychiatric hospitalization, so he said, I don't want to go. So we decided to manage this outpatient. So we had to have a very, very close back-to-back follow-ups every week. So the first thing we tried was the neurofeedback. And he was also, he was on a bunch of psychiatric medications, which was started to him because of his condition. And he personally felt that the medicines were actually making things worse, and he really wanted to get rid of the medicines. So imagine anxiety driving his suicidal ideations, and he's saying on top of it, I don't want to be on this medicines. And then I don't want to go to the psych hospital. So we really manage this per patient in the clinic level with our interdisciplinary approach. And so first thing was we put him on a neurofeedback. We said, well, we're going to taper you off the medicines, but we need some support to do that. And your anxiety is the driver. So we did neurofeedback. We said, well, let's try this. And I think, there's some evidence with anxiety and what you have. And he responded, with the support of neurofeedback, we were able to get rid of his medicines without causing a decompensation. He still had the lurking symptoms. Once we completed the neurofeedback, we reassessed him, measured his cognition, and then we decided to go with TMS. Now, this time we did as a brain map. Like I said, there are two networks. One is anxiety and one is depression. And there's tasks where you get stuck in your brain and stuck out of your brain. So we wanted to understand which network suited his best clinical evaluation or deficits. And we identified the default mode network, which we thought might be the best network to target. So we mapped his brain, we targeted this, and even with the TMS, we did an accelerated approach. Normally TMS is done once or twice a day for about 4 to 6 weeks. And we do about 35 to 35 sessions for the entire duration of treatment. with him, we decided to actually do 35 treatments in 1 week. That means we did about 7 sessions a day. So we did that, and suddenly things changed. He's, first of all, I just saw him last week, clinically doing much, much better. He came with his wife, and wife was extremely pleased. He's actually finally able to have a laugh with his family and joke around and live his normal life. An amazing clinical subjective improvement. And the great thing is, he's off all medicines. He didn't need them. He was right. So, he was absolutely right. He said from day one, my medicines are making me worse. And, that's what it is. A lot of times in concussion, you really have to listen to your patients. And, it's not like you're an expert, you're learning from your patient. So, and that was the right thing to do. Today, he's symptom-free. He's on a constant trajectory of improvement. And this is data from May. And I think, you can see here on the mood, look at the mood, January 27th, May it was peaking. And this is July 2021, 15. Look at the improvements here. Sleep is gone. He's fine. There's no problems with this REM behavior disorder. And even the cognition is getting better. Look at the scores. Previously he was having problems with his verbal short-term memory capacity. That was the 86 was the baseline, and now he's on that trajectory. His spatial short-term memory, which is a normal verbal form of memory. Again, even that is slowly starting to trickle up. And his working memory. It's like a temporary. It's very commonly affected in patients with concussion. Look at that trajectory going up. So this is so you really have to monitor them as well. It's not like just you did it and you're done, and you really have to track and understand how it pans out, how the other variables are featuring. As a result of targeting his anxiety, his headaches are bad. So really, I don't think we would have got to this extent of results if not for the team effort. It's not one individual did everything. It's understanding every critical resource that every member of the team brings to the table. So this is another patient. Now this time it's a veteran. He's a veteran of multiple concussions. He's had concussions, and ironically, he's not been diagnosed with concussion by simply because of the fact that his imaging was normal. It's a very common practice we see here. It's like MRI is only about 35 to 40% sensitive, and a lot of times it's not just him. I can give you another example of a physician who's a physician, and she had a concussion, and she went to a local doctor, and he said, well, your MRI is normal. I don't think you have any problem. But she's saying, I have a problem. I have symptoms, but your MRI is normal. So that means nothing can be done. So it's a, that's why it's called as a hidden injury, right? So you just can't say your MRI is normal, so you don't have concussions, post-concussive syndrome. So unfortunately, the system is like that. So, that's something that we need to address at some point. Nevertheless, so he did have multiple concussions without loss of consciousness. Like I said, you just can't say just because you don't have loss of consciousness, you don't have concussions. He did have all the classic symptoms of post-concussive syndrome, migraine headaches, cognitive difficulties. 44-year-old guy shouldn't be having that kind of a cognitive impairment, and severe treatment-resistant depression. So again, it was a team effort. All the same players were, usual suspects were involved: sleep medicine, headache neurology, cognitive rehab. I'm sorry, my apologies. In his case, cognitive rehab was not used, but again, through the same approach. This time, we used a different method. We added TMS with other forms of we did a little bit of Spravato as well after we transitioned, and we found great results. The results are such that we went to the emergency room to be hospitalized, and he's had fleeting suicidal thoughts in the past. So we've been able to successfully manage him without being hospitalized. And as of last week, we transitioned him, and he's doing relatively much better. He was at high risk for self-harm. He was high risk for severe psychiatric decompensation, going on disability. So we slow, this has been, the outcome of what we have had now was very, very pleasing, especially he's young. He's got lots of, functional years ahead of him. So I think, not just improving his symptoms, we're also trying to get him back to his baseline functionality of his previous job. So I think that's very reassuring. And then, this is another patient who is a, executive. He is an executive who trains executive in coaching, and, he had a bad TBI, and his TBI was back. He had a TBI, he was hit by a car, he was on the road, and he was hit by another car because they didn't see him on the back-to-back. Really bad one, he was a high cognitive, high level of functioning. Suddenly he started to have migraine headaches, vision problems. So we did that, virtual reality test to parse that out, address that. Apathetic depression. He just didn't feel like doing anything. He would just imagining a coach having apathetic depression. So he can't work. He can't work as a coach. A lot of cognitive impairments, slow thinking. He writes books. He could no longer write books. So we again, we did the MRI. It showed this DTI, which is kind of a sequencing that looks at the axonal damage, and we found that was positive. Again, we did the, again in his case, we felt that this time his depression was not anxiety, as the previous first case I presented, that was anxiety depression. He was more apathetic depression. So we mapped his brain. Again, I don't have the picture here, but we did a similar thing. We mapped his brain and target that apathy area in the brain with TMS, and voila. And again, we also added cognitive rehab. My colleague, Dr. Jennifer Sumner, was simultaneously doing cognitive training along with the TMS. And he improved quite a bit. And he's almost 80% back to his baseline job function. Headaches have improved. Overall sleep is improved. So again, the same usual suspects were part of the whole team. And finally, we were not just able to control his symptoms, get his, get him back to his baseline functionality. And all these patients, we also, like I said, our approach is not to address the current problems, but look at overall brain health and mitigate the risk of future Alzheimer's or CTE. So we track them. We have his CSF, they're part of the study, and we have their, every 6 months to a year, we do their lumbar puncture to make sure that we're tracking their amyloid and tau proteins, and seeing if there's any change in that. So there's also this monitoring process with biomarkers going on. And this is his results. I mean, where he was, like, if you look at this graph on the left side, the higher on the y-axis, higher the score, the worse it is. And the x-axis, the lower, the better. So you see 20 to 4 severe improvement. A lot of them, you see a very similar in depression. This is anxiety scale. This is a headache scale. This is depression scale. This is another depression scale that's a little bit more broader. So overall, we see a functional improvement as well. So that's great. So all right, so that brings me to it. So yeah, so I will stop here. I think I gave you a little bit of overview about what we have done. There's in-depth about we can talk all day about individual specific treatments like the TMS or the neurofeedback or the cognitive rehab or lifestyle modification. So there's lots of data that we have that we can talk, but I'll stop here for now, and I'll be happy to take any questions. Thank you everyone. Thank you for your attention and listening.
A couple of points before we get into some of these questions. A couple things sort of came up for me is as you were mentioning a few times about scans and MRI, and it's very common. I mean, we get calls all the time where people go, I'm having deficits. They were offered a scan and told, classic story, your scan is clear, everything's fine, but they know they're facing challenges. I mean, I myself, dealt with this, full disclosure, in 1989 after a car accident, and sort of left on my own, just to kind of hope that things improved, but definitely noticed that I had deficits. So, it's great to, to have a resource, like you, and Kaizen Brain Center, where folks can maybe have an opportunity to dig a little bit deeper and get a more well-rounded assessment and treatment plan. It's just unfortunate that that's often not available to people through traditional HMO insurance and that kind of thing, right? And so I guess that's not really a question, but I guess part of the question is, do you take insurance, or how can somebody who's, faced a situation like that, how can they potentially avail themselves of, your services and assessment processes?
Yeah, it's a very good question, Kurt. The biggest hurdle to us providing care is the insurance. I mean, it's ironic that, most of the services that, insurance does not always follow science. It lags behind, years and years behind.
Yeah,
and
exactly.
Kaizen, our biggest struggle has been the insurance. We to answer your question, we take most of the insurances, including Medicare and TRICARE. We've always taken it because TRICARE we've always been on it because a bulk of what we have trained and want to give back is the veterans who have TBIs from the war, or veterans in general, even without TBI as well. So we do take insurance. There are some services that are like not covered by the insurance at all for some odd reasons, and that we find really challenging. At Kaizen, we have tried to absorb. Remember, we started this as a scientific model. We didn't have a business model, so we did horribly as a business. Because there was, like I said, Kaizen was also started with a sense of frustration. I mean, like, I was seeing patients in the community. I'm like, how come we're not addressing this? And there was frustration. I need to just do this and start. And even if I fail, I don't care. Let's do the right thing. So great. So we struggled to kind of like put a business structure to it. But somehow we've, in 3.5 years, we've learned to kind of like collaborate with the community. That's why I think, one of the talks that you and I have talked is we can't do everything alone. We need partners. We need resource. We need a good partner in SDBIF who can be a, great community resource where, there's some, there are, where they can step in and when there's like, for example, cognitive rehab. Right? Just take that example. I mean, this is an intervention that was developed in the Veterans Hospital for the veterans with brain injury. All right. So you should have that resource, and there's evidence-based, right? So when you come out of the Veterans Hospital, there should be it. No, there's none. How do we go around this, and how do I do? I don't do that. I mean, I have a colleague who does that, and she's not a part of the insurance. Now, how do I make that happen? And, I think that's where we need to figure out. That's where I think I can't do everything, or one person can't do anything. I mean, the DivBIC has all the resources and they have everything, they can do it. But, but in a community-based level, we need a team, we need resources.
Yeah, I totally agree. And there's that community reintegration component as well that's so important and ties into that. Somebody had a question, and asked it a couple times, and I think it's an important question, right? Because some folks may be 20 years, 30 years, 15 years post-injury, and they're still, having deficits. So someone asked, is there a timeline whereby one, has had a brain injury, the area for improvement becomes less productive? So maybe 10, 20 years post-injury, does the area for improvement become less productive? Or is there a timeline when things like the sync think evaluation becomes less productive in the evaluation process?
Yeah, that's a very good point. So, I will try to answer this question. It's a very good question, but I'm not sure if I fully understood. Let me try to answer this, but whoever asked the question, they can ask again if I didn't answer that adequately. Listen, you have to understand TBI from a scientific perspective first. What really happens when you have a TBI is you have a neuroinflammation. Within 10 days, your brain is in a state of an inflammatory state. And normally that resolves. In people where it doesn't resolve, you have this long-term sequelae. All right. Now, So timing is critical when you intervene in the spectrum of the syndrome. So the icing that I showed is largely for people with immediately who have a concussion. So it's a device that's how Stanford uses it in the sports concussion in games where you have a concussion. Previously, what they would do is if you were in a game and I had a concussion, they'd ask you this cognitive testing, what's today's date, blah, blah, blah. But this was the first objective measure of looking at your visual function after a concussion. So that to answer your question, it has a more validity in using an acute concussion. I think, but in our practice, we've also used in patients who had chronic concussion. We really don't know whether you can make a conclusive diagnosis out of that because we don't know the baseline. But it's one of the tools within the whole evaluation that can help you with the kind of like that gives you some critical information to make a management and diagnostic plan. Does it answer the question?
I was making reference to, of course, Ernie's situation where he had a stroke and he has a vision impairment. And I was wondering if there was a timeline at some point where those neural pathways cannot be reopened or regenerated or recreated, because it's difficult for most of us that have experienced that to have those vision impacts. So I was just curious.
Yeah, it's a good point. So the answer is perhaps no. This tool may largely be effective in the acute stage. What happens is that your eyes, everything compensates. You've compensated your neural circuits and all these things have tried to because of some degree of a regenerative processes have learned to compensate around the deficit. What I would recommend is a good concussion trained neuro-optometrist. Like I said, I've had amazing success with Dr. Lisa Weiss, W-E-I-S-S. People also may have issues with convergence. So at that point, you need a little bit more comprehensive than just doing the one visual testing that we usually do in the acute concussion.
Right. Thank you.
Yeah, thank you very much. And I love that, you shared some graphs and some data. And I really love that you put, data and metrics behind, your assessment, treatment, and monitoring progress, and really take the approach of looking at how things are changing and trying different things, because there's no one size fits all. There's no one approach for anybody. A survivor once told me that brain injury is like a fingerprint and it's different for everybody. And I'll never forget that. And it's so important that, medical professionals take a real holistic approach to, really assessment, diagnosis and treatment. Let's see, I had a question about, bear with me on my notes, about the icing, vestibular assessment and oculomotor. I can't say that correctly. Is that kind of what like a functional neurologist would do as well? Because that's like a medical discipline that a lot of people are, it's mysterious to a lot of people, but I've been to a local clinic, I won't mention the name, and it looked like they, were doing some of that, but I don't know if they called it the same thing. I don't know if you can comment on that. Is that's something that somebody can get from a functional neurologist as well?
I don't know. Honestly, I can't comment because I don't know exactly what they're doing.
No problem. Yeah.
I think is, it's come from the lab of Stanford Concussion Center. Jamshed Gajar, who actually is being the founder of this device, is a fully trained neurosurgeon at Stanford. So, this is, I don't think this has got a functional neurology aspect of this particular device. It's very objective, very scientifically validated tool. Again, but I think, to answer your question, which is very important, I think there's a larger problem here that I wanted to address. I think one of the things that I want to state is that, concussion somehow has been a very sort of like a cool word, right? So football, NFL, whatnot, and blah, blah, blah. And there's a race to invent something unique tool to diagnose and stuff. So, you cannot diagnose concussion with one tool. That's the problem. I think there are people do scan and say, wow, look at this. Our scan said you have concussion. We have this. You cannot. In fact, you have to, like I said, nothing is more important than a fundamental, good, solid clinical neurobehavioral exam. And then you utilize the tool that you want to confirm your diagnosis physically. So I think the whole setup is designed to fail. That's my worry. And not just designed to fail, it drains. I mean, if goodness, the amount of money people have spent on this, there's a lot of snake oil around here.
I know, there really is. And that's exactly, I'm glad you used that term and said that.
Sorry for the patients who've been misguided and done this fancy things which has absolutely no validity whatsoever, and thousands and thousands of dollars. And I just don't know I don't know what they're talking about, what kind of scanning they do.
Yeah.
No better than please go ahead and they say, well, here's your diagnosis and that's it, we're done. And I'm like, what?
What next? What does that mean?
What does it mean? Exactly. So I think we've got to be careful with making, so my impression is, one tool is not a diagnostic tool for everything. Even that's what they claim. Even if you look at the research data, it's just designed to pick up, like you really have to go back to drill down to science. I mean, I have patients who say, well, my diagnosis is I have a TBI. Well, you don't have a TBI. Let's correct that. You had a TBI, and that's a historical event. A historical neurological event of TBI happened that caused
these other things
in your brain. What you really have is a postconcussive syndrome. Let's characterize that. So the question is, can you treat TBI? I say, I can't treat TBI. Nobody can treat TBI. It's a historical event. What we do is we treat your remnants. We treat your postconcussive syndrome. How am I supposed to go and treat a TBI that happened a long time ago? And as already, it's like a tsunami has come and it's caused devastation and gone, returned. I don't go back and treat the tsunami. I treat what is, what damage it has caused, right? So I think there should be a lot of public awareness, and I think also we take the blame because we haven't done a good awareness campaign. That's how people are getting into this, lots of snake oil, because a lot of people are luring them into this fancy things that have no validity at all. So I think that's why, I think you and I have talked that we need an organization, SDBIF, to and talk about science and spread the real science.
Yeah.
So I think.
Thank you for putting it that way. And I am a big advocate for, just talking more about this and legitimate, science and resources. And so thank you for putting it in that perspective. Yeah. And the right team is critical too, because again, it's fragmented, and there's providers out there that, maybe are less than legitimate. And we see a lot of folks these days, kind of jumping into the brain injury assessment, diagnosis and treatment world. And so I think that, as a community, we just have to be well educated, and, we can disseminate, hopefully good information to folks that provide them a bit of a path forward in this process. Thank you. And someone else says, and this is so common, and there's not a great answer to this, right, in our community, but maybe you're part of the approach or answer. But Stephen had said he had suffered a TBI from an assault in 2019. He's just classic story, right? All he's gotten is one basic MRI. His MRI wasn't clear; it did show damage. And how do you find help? And it's almost like this approach of the medical community where it's like, okay, well, you have some damage and there's nothing we can do about it, and here you go, and you're on your way, and hopefully things get better over time, right? I mean, we kind of hear a story like that, and isn't there something that as a community we can do more proactively with folks? Can't survivors do something more proactively as opposed to just being told, yeah, you've got some damage and there's not much we can do about it?
Time, yes. When I hear that stories like, oh, we can't do anything about it, absolutely wrong. Absolutely. See, that's why on purpose I put up those slides about the treatment options like medicines out there. I want to state this again. It doesn't matter where your headache came from or your depression came from. Whether it came from a stroke, from a TBI, it's still a depression. Treat it. So when people say we can't do anything about it, see, that's exactly the point, right? You're not treating the historical neurological event.
Exactly. Yeah.
You're treating the current symptom. See, this is the fundamental difference. I think, it goes back to the, thank God I trained as a neuroscientist, So, see, that's what it is. I think I also made the statement, the neurological event of a TBI translates into a neuropsychiatric syndrome. And that is a very important point I think I want to restate, is because not because I trained as a neuropsychiatrist, but I think, the quarterback, the driver of your the central driver of your TBI care should be a neuropsychiatrist. No offense to neurology colleagues or, just psychiatric colleagues or anything, but this is what it is. I mean, this is you have to have the training and experience in TBI to be the driver. I think that's lacking. It's like, imagine, the typical, you just go to a person who's you go and see, and if you're just going to rely on the MRI and say, well, your MRI is normal. I don't care about whether your mood is dysregulated, you're crying too much, who cares about it? Your MRI is normal. So that's all I care about. And so I don't think you have a problem. It can't be that way. Yeah. So I think it's that, it's that, who's your driver? I think it's a critical point. It's a critical point that it's a system. It's a system that has happened. When I first came to San Diego in 2013, I trained in concussion, and it was like still there was like I didn't know much about concussion despite having some training and stuff, and I was still struggling to help see what's the right thing. When I came to California, I was like, there's like a gazillion concussion centers here, and I thought, oh my God, I wasted all my career and training, and I should have been here a long time ago. But the problem is that like I said, I think every time business overtakes science, then we get into the state where we have cool clinics doing all marketing all fancy things without lack of scientific validity and evidence. I think we need to get back to science. I mean, we need to get back to the progression of the condition, fundamentals about how this is a chronic condition, not just a one-time acute condition. So I think that's what we need to do. That's why even CDC calls TBI as a hidden injury. You could be having perfectly normal individuals walking around, and then the next day they shoot themselves. Not too long ago, last week, we had a veteran who just was perfectly, just shot himself. So these are things that happen, and I see that, I have, I tell my wife, I don't think, I started, like I said, I don't think I've slept in 3 years because I do get nightmares about things that I think I could have done better. And some of the patients that I follow, and I'm like, I think that, he's at risk for doing something. There's always this fear and stuff. So, the classic symptom of CTE or people with concussion is the short fuse, right? They go from 0 to 100 in no time. So impulsivity, unpredictability are the key variables that you're dealing with. So it needs a team effort.
Well, we'll continue to advocate, and hopefully, the HMO systems and things like that start catching up to some of the science that's going on, the research that's going on, and some of the things that that you are doing. All right. Well, thank you. I'd like to give you a little round of applause here. I mean, I really appreciate you spending some time with us. It's an exceptional presentation, and just hearing your approach to assessment, diagnosis and treatment is exceptional. So thank you so much.
Thank you. Thank you. I want to say thank you everyone for listening and tuning in on a Saturday, which is not easy. But thank you so much. I just want to say it's an effort to try to do the best thing, and I've not always succeeded. I've also have failures as well. But I think we have to learn from it, and I think I'm really thankful to everyone, all my patients, especially the veterans who we've treated, and for teaching me. I think every concussion is different, and through them I learn and we grow together. So the effort is to provide the best care.